Hello everyone, my name is Amr Elkamshoushy, and this lecture will be about pediatric ophthalmology. First, I want to explain a term called amblyopia. Amblyopia has an alternative name that's described as lazy eye. This is a neurodevelopmental visual disorder. Usually occurs unilateral. It's less commonly bilateral. You can diagnose it by measuring the best corrected visual acuity. Amblyopia means that this visual acuity is reduced. The patient must not be able to see 6/6 with his glasses. If he wears his glasses and he can see 6/6, then this is not amblyopia. So amblyopia can be diagnosed when you measure the visual acuity with the full correction with the glasses and the eye cannot see well, in spite of not having a pathology in the eye. So if there is a cataract, or if there is for example, an optic atrophy or any other disease in the eye causing the vision to be poor, then this is not amblyopia. Amblyopia is caused by an abnormal visual experience early in life. For example, if the patient has a cataract in one eye, the brain would ignore this eye for quite some time when the child is young. And even after you remove this cataract, the vision will not go back to being normal. And this should be treated by patching, as we will explain later. What are the predisposing factors for amblyopia? What would cause an amblyopia? Number one, strabismus. Strabismus is ocular misalignment, when the one eye is fixing and the other eye is deviated, whether inward, esotropia, or outward, exotropia. And amblyopia is more common in cases of esotropia. So the brain uses the eye that fixes for vision and ignores the eye that is not fixing. And this eventually leads to poor visual acuity in this eye and amblyopia. Number two is anisometropia. Anisometropia is asymmetric refractive error. And to be more accurate here, we should say that the predisposing factor is uncorrected anisometropia. What I mean by that is, for example, one eye is emmetrope. Emmetrope means it has no refractive error. And the other eye is a myope -8. So if he's not wearing his glasses, the child would always use the eye that is fixing for vision, the eye with the better vision, without the refractive error, and would not use the eye with the -8, and eventually leads to amblyopia. So if he doesn't wear his glasses early in age, when he grows old and he wears these glasses, you'll find that the vision is still poor, even if he's wearing the -8. The same happens with hyperopic refractive error. If one eye is emmetrope and the other eye is a hyperope, for example, a +5 or a +6, and he doesn't wear his glasses, this is going to cause amblyopia in the eye that is hyperopic. This is called anisometropic amblyopia. Number three is form deprivation and occlusion amblyopia. Any opacity in the ocular media, such as cataract, corneal scarring, upper lid ptosis, if the lid covers the eye, all this would deprive the eye of the visual stimulation and cause amblyopia. Bilateral high uncorrected refractive error may cause amblyopia, but the error should be high, and this is actually the least common cause of amblyopia. We have to know that amblyopia only occurs in children and can be treated in children. If any of these causes of predisposing factors happen in someone who's an adult, it will not cause an amblyopia. How to detect amblyopia? It's diagnosed when the visual acuity is less than normal, with no pathology seen in the eye. In the very young children, you cannot really measure visual acuity with charts. You measure visual acuity using the fix and follow methods, or the preference if he prefers one eye over the other. In older children, you can use the charts. In very young children, these children would show resistance to occlusion of one eye. If he sees good in one eye and he doesn't see good with the other eye, the child would cry when you cover the better seeing eye. Prognosis. Prognosis is, what do we expect after we treat this condition? Amblyopia, the prognosis of amblyopia usually depends on the age at detection. If we detect amblyopia early in age, 1 year old or 2 years old, and we start treatment, usually the prognosis is very good. The older the child is at the time of detection, the less response we have for treatment. Usually after the age of 9 or 10 years, it will be very difficult to treat amblyopia, and you cannot treat amblyopia in adults. So how to treat amblyopia? Number one, once you find amblyopia, you should treat it in the child as early as possible. You have to treat the cause. If there is an isometropia, treat it by glasses. If there is a cataract, remove it. If there is a media opacity, handle it. Number 2, you have to try to push the child to use the amblyopic eye more than the non-amblyopic eye. The most common is using occlusion therapy. Occlusion therapy is patching the normal eye. So you just put a patch on the normal eye a few hours every day to force the child to use the other eye, which is amblyopic. The other option is using atropine cycloplegic eye drops. Using atropine eye drops in the better seeing eye, not in the amblyopic eye. So when you put atropine in the better seeing eye, this will blur the eye because the child will lose accommodation in this eye. So he will be forced to use the amblyopic eye, and this stimulates the vision in it. So there are 2 ways to treat amblyopia by occlusion. Both ways work with the same mechanism, stimulation of the poor eye, the amblyopic eye, by making the vision in the better seeing eye less, whether by occluding the better seeing eye or by putting atropine eye drops in this better seeing eye. Now we move on to something very important. It's called the red reflex test. This red reflex test is essential for anyone practicing medicine, whether you're going to be an ophthalmologist or a pediatrician or a neurosurgeon. Any specialty should always look at a child or at an adult at the red reflex. It is an essential component of the neonatal, infant, and child physical examination. It should be done by all pediatricians in all well-child visits, because this is a very good screening test. It detects a lot of pathology in the eye, and you can detect it early and treat it early. And as I mentioned in the previous slide, that if you detect pathology in the eye of the child early, you can treat it early, and you can get very good prognosis with treatment of amblyopia. So you need to do the screening test early in age to detect the problem and treat it early. So it is vital for early detection of vision and potentially life-threatening abnormalities such as cataracts, glaucoma, retinoblastoma. So many pediatric eye diseases can only be detected using the red reflex test. The red reflex test is you use the ophthalmoscope to look at the reflection of the blood vessels of the retina. And as you can see here in the image, in the top image you should see equal red reflex in both eyes. If you see lost red reflex in one eye or yellowish reflex in one eye, that means there is a pathology. The red reflex will be dim in an eye with a media opacity. So if you look at the images here, the top image with the green text, this is normal. The second image, there is an X on the left eye, as you can see, because the red reflex is absent. It's black. It's a dim red reflex. It can be dim or it can be completely absent. And in both situations, that means there is either a media opacity or a red reflex or a refractive error. The third image, this yellowish reflex, is a sign of retinoblastoma or retinal detachment. Both retinoblastoma is a life-threatening situation. Retinal detachment is a vision-threatening situation. So any child which you do red reflex and you find asymmetry in the red reflex, you should refer the child immediately to an ophthalmologist to treat him early. This brings us to a very important definition, something called leukocoria. Leukocoria is a whitish reflex instead of the red reflex. As you can see in the pupil here of this child, in his right eye, the reflex is yellowish. So when you do a red reflex test, use the ophthalmoscope to look at the eye, and rather than seeing a red reflection of the retinal blood vessels, you see a yellowish reflex. What's the differential diagnosis of leukocoria? The differential diagnosis of leukocoria is very important. It's a very important exam question. It's very important in your practice. You have to understand that cataract is the most common. If there is a cataract, you will see a yellowish reflex. Retinoblastoma, number 2, it's a malignant tumor of the eye. It's not the most common, but it's the most dangerous. So seeing this reflex, yellowish reflex, and referring the child early could save his life. Retinopathy of prematurity, we're going to come to that later, which is a retinal disease caused by oxygen treatment in premature children. Persistent hyperplastic primary vitreous or persistent vital vasculature is a congenital condition in the eye affecting the visual acuity. Toxocariasis, of course, you're aware of this, is a parasitic disease. Retinal detachment, which is a vision-threatening condition that should be treated. And lastly, Coast disease, it's an exudative retinal telangiectasia, usually diagnosed in a little bit older children. Pediatric cataract is of special importance, and it has some inherent differences from adult cataract. Cataract, like any cataract, is a crystalline lens opacification. Pediatric cataract is opacification of the lens in the pediatric age group. It can be congenital, present at birth, or developmental, which develops in the first few years in life. The presentation is usually a little bit different from adult cataract in that in so many situations there is usually is associated with other anomalies, other diseases like genetic and metabolic diseases. If intrauterine infections can cause pediatric cataract. So when you see a pediatric cataract, you should investigate the child for other conditions that may be there. It can be unilateral or it can be bilateral. It can be mild, not affecting the vision very much, like the blue dot cataract, and we don't operate on them when it's very mild. And sometimes it's significant dense cataract like the lamellar, and we have to operate it. When it's completely white, it causes what's called it causes a sign called leukocoria, which we just mentioned in the last slide. Treatment of pediatric cataract is just like any cataract. You can treat it by surgery. You remove the cataract and you insert an intraocular lens. However, of special note is that pediatric cataract should be treated quickly, not like adult cataract. Adult cataract can wait for months, no problem. But pediatric cataract, if you wait for a long time, it can cause amblyopia and will be more difficult to treat the amblyopia. The longer you leave the cataract without treatment, the more time it will take to treat the amblyopia that will happen after it. So if treated late or left untreated, unilateral cataract can lead to sensory squint, while bilateral cataract can lead to nystagmus with poor visual prognosis for both conditions. The second bullet point here is important, that why do you have to treat pediatric cataract early? The treatment is surgery, of course. You remove and you may put the intraocular lens early, called primary implantation. It means at the same surgery where you remove the cataract, you put an intraocular lens, or you can put that intraocular lens later in life, because the child's eye grow and the measurement of this lens can change with time. So sometimes in very young children we don't put an intraocular lens and we keep it till a later age. Instead, if we don't put an intraocular lens, the child can wear glasses in order to see during the few years in which he will be aphakic. By aphakic, I mean he will not have an intraocular lens. Nasolacrimal duct obstruction. This is a very common condition. Happens maybe in 1 every 5 or 6 newborn children. The nasolacrimal duct, as you may well know, it's a duct draining the tears from the eye to the nasal cavity. And there is a puncti at the nasal part of the eye, 2 puncti and the caniculi, and that drains in the lacrimal sac and down into the nasolacrimal duct. Nasolacrimal duct means it's from the lacrimal sac down to the nose. Children sometimes are born with obstruction of this nasolacrimal duct. When it's obstructed, the symptoms usually appear very early. The symptoms can be epiphora, a lot of tearing coming out of the eye, and recurrent infection. The clinical picture is very characteristic. Epiphora, which means a lot of tears, crusting, discharge, and recurrent conjunctivitis, because there is stagnation of the tears and recurrent infection happens. Reflux of mucopurulent material from the lacrimal punctum when pressure is applied over the lacrimal sac. So if this lacrimal sac here contains a lot of pus, when you press on it, the discharge comes out through the punctum, because this cannot go down in the nasolacrimal duct. If the lacrimal sac becomes distended with mucus, it's called mucocele. And this is the picture that we see down here, that there is a mucocele. This lacrimal sac is distended and full of mucus, and it may become infected and cause a lacrimal abscess. However, this is not common to occur in cases with nasolacrimal duct obstruction. How do we treat nasolacrimal duct obstruction? About 85, maybe more, 85% of the cases or more resolve without surgical intervention before the first year. So, therefore, we only wait on these cases until they get to be 1 year of age. Most of them resolve before that age. Massage over the lacrimal sac at the medial corner of the eyelid. It increases the pressure when you do massage, daily massage on this part. This increases the pressure in the nasolacrimal duct and may help in the canalization. If the child reaches the age of 1 year and still the nasolacrimal duct is obstructed, we can do a probing, surgery. You probe the nasolacrimal duct through the punctum, you insert the probe through the punctum and down to the nasal cavity in order to open the duct by this probe. Well, we usually wait until the age of 1 year because a lot of children resolve without having to do this surgery. A mucocele needs probing early because when the sac is distended with mucus, it's prone to infection, and of course, if there is infection and the lacrimal abscess, then we need to incise it and drain it. Ophthalmia neonatorum. This is the type of conjunctivitis that takes place in the neonatal period, and it can have severe complications such as corneal ulcer or perforation. Although not common, but it can be severe, therefore should always be noted. This is important for any pediatrician, especially a neonatologist who sees children in the very first days, or very first hours actually, after being born. What causes infection, this conjunctivitis in newborn children, is caused by infection from the birth canal. The child passing through the birth canal may catch this infection in the eye. That being said, we should say that children born by cesarean section do not have the risk of having ophthalmia neonatorum. What kind of infections can happen? Since he gets the infection from the birth canal, so we look at the infections in the birth canal, can be sexually transmitted diseases like the Neisseria gonorrhea, which is the most severe, causing purulent conjunctivitis that has a lot of pus, chlamydia trachomatis with all its types, herpes simplex. All these are sexually transmitted diseases that can be present in the birth canal. Non-sexually transmitted diseases as staph and strep and Haemophilus, these are regular bacteria that can be present there in the birth canal and not sexually transmitted. These types of organisms can cause ophthalmia neonatorum. Diagnosis is again easy. You see a clinical picture of infectious conjunctivitis, which is the injection, the discharge in the newborn child, and you can do culture to confirm that. Treatment and prevention. The gonococcal ophthalmia neonatorum should be treated very early. So once you diagnose gonococci, which is severe purulent discharge, you should take systemic and topical antibiotics. And this is very important and should be noted by pediatricians that this is not a condition to be taken lightly, because the infection can spread systemically and cause septicemia. So gonococcal ophthalmia neonatorum should be treated with systemic antibiotics, not only eye drops. Chlamydia infection is treated by oral erythromycin, it's less severe. And of course, the best is to prevent the ophthalmia neonatorum. When you have a mother suspected with STDs, you should always treat the mother before birth and give the child topical erythromycin eye ointments once they're born, before the infection develops into becoming more severe. Primary congenital glaucoma. That's a rare condition that is caused by abnormalities in trabecular meshwork and the anterior chamber angle, causing the child to have an elevated intraocular pressure that usually appears in the first few months of life. This, in contrast to adult glaucoma is a common condition, but primary congenital glaucoma is a much less common condition, and the cause of it is impairment of drainage at the angle of the anterior chamber. It's a difficult disease to treat. It's blamed for a lot of word blindness and should be treated carefully and very early. These children usually undergo a lot of surgeries, and although we do a lot of surgeries early, not all of them end up well, and a lot of children may lose vision in primary congenital glaucoma. The vision loss is secondary to corneal scarring or the optic nerve damage that happens, and even if these two are treated early, there is usually a lot of amblyopia and anisometropia that also adds to the visual problem. However, with timely proper control of IOP, the vision can be salvaged to a certain extent. The symptoms: elevated intraocular pressure with subsequent corneal edema causes irritation and associated with the classic triad of symptoms. Photophobia. So these symptoms should be noted very well by the pediatrician to be able to refer the child on time. Photophobia means the child is disturbed by light. He cannot handle light. He usually closes his eyes when he looks at bright light. Tearing and blepharospasm. Always closing the eyelids, and there's a lot of tears, and the child is irritated a lot by light. And the signs are very easy to diagnose: increased intraocular pressure when it's measured, enlarged cloudy cornea, and ophthalmos. The word ophthalmos means the eye of an ox, because the eyes are usually big and blue as the image that you can see here. So when you see an infant with the eyes bigger than normal, you should always suspect that this is glaucoma. Intraocular pressure can make the eye grow in size in children. However, that does not happen in adults, because the eye in children, the sclera is extendable and it can grow in size when there is high intraocular pressure. However, in adult glaucoma, that does not happen. No matter how high the intraocular pressure is in an adult, the eye will not grow in size. Treatment of primary congenital glaucoma is mainly surgical. It should be done early, before we reach a condition like the one you see in the picture where there is corneal scarring. Because if there is a scar in the cornea and the cornea is opacified, even after you normalize the intraocular pressure, the vision will not be good because of the corneal opacity. The differential diagnosis here can be tricky because this is an infant. If you look at differential diagnosis of epiphora, nasolacrimal duct obstruction, of course, comes as the top differential diagnosis because it's the most common cause of epiphora in children. Other causes of conjunctivitis or corneal abrasion or corneal infections can cause epiphora. The corneal clouding or opacification can happen from birth trauma, or some congenital conditions like the scelocornea can cause corneal clouding, or inborn error of metabolism, mucopolysaccharidosis. All the diseases of mucopolysaccharidosis can cause corneal clouding, which may mimic primary congenital glaucoma, but it will not have the enlarged eye and the epiphora. Corneal enlargement can happen in a condition called megalocornea, which is a large cornea, but not due to raised intraocular pressure, or high myopia, because myopic eyes are usually larger than normal sized eyes. Thank you.